very long time, and was asked to start an IV, help start IVs in the rheumatology suite. And I figured I'd be there a couple of hours, and that was 13 years ago. I felt.
Coach, you actually forgot you were supposed to be there.
Thank you very much. So, yeah, I forgot that I was supposed to be there. They called and said, weren't you going to come and help us today? And I was like, oh yeah, shoot, I'll be right there. So I came and yeah, Kevin, I read about Remicade and was just petrified. I was shaking because I read all the side effects and I thought, oh my gosh, what happened? Oh my gosh. And the lady walked in with a walker and walked out carrying a walker, and I thought, wow. So I didn't make the drug, all I did was administer the drug, and I thought, if that's what this is all about, and that was a long time ago, 6 years ago, in my 14th birthday. So I love it. I absolutely love it. And I think that the biggest thing about rheumatology is that you get to share the whole patient. So I tell all the nurses, you get to take care of the whole person. You just take care of the heart. You don't just take care of the lungs. You take care of the whole patient. And what a fabulous experience that is. So, pardon me, I'm going to use some notes because I have some quotes from some of my coworkers. You'll recognize some of them. So I have to put my spectacles on. But this RNVC stands for board certified. So I was one of the first 10 nurses to be board certified by ANCC. It was a lot of work, and you sit in the room with a statistician. And I thought I would die before we finished because it was just a lot of tedious work. But it's pretty exciting to be board certified. I'll tell you, I didn't realize that ANC essentially had no idea. So, no wonder. So, pardon the specs, but I want to make sure I don't miss any of the quotes that I've written down. So, I'm going to talk about labs. I shared with some of you when you came in that my very first day in rheumatology, I went from being pretty good in ICU with everything to the doc said to me, did you order an SSA and an SSB and a Smith and a Rowe and a RF and an ANA? And I was like, well, I don't think so. Because I'm not sure I know what any of those are. And I will tell you that the rheumatology teaching tool became my best friend when you finally wrote it. I was like, and so all the PAs who come to my office, I give them one of those because they're just stymied by all the labs. And I thought, you know, if there's some way I can make this easier for you, I can relate to being petrified. I'm carrying a card around in my pocket going, I don't know what any of these mean. So I'm going to try. Please, if you have questions, I would just invite you to ask them. This is, as I said, this is free-flowing. I don't want you to feel like you can't ask the question at the time. So just we'll move forward together. And as I said, pardon, I'm going to use a few notes just because I want to make sure I address everything. So these are all the labs that we're going to do tonight together as a group. So remember that when we talk about antibodies, we're going to talk about rheumatoid factor, FACCP, and ANA. And the antigen, unfortunately, is our patient. And then we're going to talk here about rheumatoid factor are the autoantibody proteins that are in response to the antigen, the FC portion. So if you look at the FC portion right here, this long skinny guy, to me this reminds me of like a miner's fork. And the top part, the Fab, the foreign antibody binding, is the one that seeks out the antigen, sends a message down the FC portion, and then starts that immunological cascade of IgM. And I'm sure you remember all that from nursing school, right? You got it all straight when you were in nursing school, right? Well, yeah, sure. So IgM is early response to RA and is very sensitive and very specific to rheumatoid arthritis. So the rheumatoid factor can be elevated in 60–80%, but some of our patients it's already elevated when they have early RA. So we get, all the time, we get patients who come to our us who have a rheumatoid factor positive and we're just petrified. What does that mean? Do I have rheumatoid arthritis? Am I sick? And you know, the values fluctuate through activity, and the titers generally can remain high in patients even if they go into drug-induced remission. So for us, the rheumatoid factor is a marker. But our job is to differentiate it from other diseases. Again, what did I tell you? We want to look at the whole person, okay? So that's really important that you understand that as you go through the labs on this, okay? All right? Pushing. So it can be positive in many patients, but other connective tissue diseases, it can be infections, it can be malignancy, especially after radiation. The only reason I decided is I have a little story to tell you. It can be positive with biliary cirrhosis. It can be positive in patients who don't have any disease. It can also be with infection. It can be with mixed connective tissue. It can be 25% of the patients over 65. By the way, over 65 is older than research. So I'm not sure how that settles with some of us who don't think of ourselves as older, you know? So, and Iris wrote an article where she mentioned that according to the CDC, don't forget to check HIV. Don't forget to check Hep C. So there are a lot of things where HIV is both very specific and very sensitive. And both of them, HIV is positive, it's sensitive, and specific to the disease. So there are a lot of things that the rheumatoid factor is positive. The reason I was pondering for a second, pardon me, I had a lady call and she said that she had read rheumatoid factor that's positive. She was sure she had cancer. And could I do a pap smear and could I do a vaginal exam on her? And she's sure she had cancer because her rheumatoid factor was positive. This was just yesterday. And I said, because she read it on Google, you know. And I said, oh dear, but no, we don't do pap smears and we don't do vaginal exams. But I have a cyst on my ovary. Are you sure that you can't do this? And I said, yes, I am sure that I can't do a vaginal exam for you. So, but she had read and she was scared. So of course I diverted her and said, you need to go talk to your OBGYN, the whole patient. So CCP is an antibody that is directed toward the patient's own individual proteins. Remember, this is an autoimmune disease. What does that mean to you? That your proteins upregulate and cause this disease. So is diabetes considered an autoimmune disease? Yeah. Is cancer considered an autoimmune disease? Yes. So it can go up inflammation. And again, when we're looking at the protein, the amino acid, what is the building block of protein? You remember that so well from nursing school, right? The amino acids, there's 21 amino acids in the building blocks of proteins. So if we sit that, then it changes the shape of the protein, and all of a sudden the immune system says, oh, you're not my friend, you're my enemy. So CCP, anything over 20 is considered positive. So anti-CCP is a biomarker that allows for early diagnosis of RA. Now, the sensitivity of anti-CCP is between 50 and 75%, and specificity of anti-CCP is 90%. So sensitivity means true positive. Okay? And the specificity means true negative. All right? So let me give you some other examples so that maybe you can focus in on this. Esterase. Esterase is very sensitive. But what does it tell us about specifically is wrong with the patient? Not much, huh? I'm going to do this one for you. TSA. You go to the airport. Everybody is a threat. We're all sensitive. We take off our shoes. We take off our belt buckles. We take our phones out of our pocket. How specific is it in finding the bad guy? Don't tell TSA, but it's not very specific, is it? Even after you get undressed and redressed. Okay? So does that help a little bit? I thought you'd like that. Because he just loves it when he has to take his shoes and his belt and take everything out of your pockets. And, okay? So the specificity for an anti-CCP is 90%. Okay? So that means it's a true negative. It's often more. Okay? So linking our rheumatoid factor to anti-CCP. Both tests are typically worn. Positive tests can either be, it's diagnostically sensitive. If both tests are positive, it increases the diagnostic specificity. It means it rules out anything else. Okay? But if the 50% of patients that are both test negative for both, what does that mean? That means you have to use some of our skills. We have to do a joint count. EULAR says you don't have to have any positive lab tests to diagnose RA. You can just have tender swollen joint count, stiffness in the morning, and a duration. Any positive lab tests to have a diagnosis of RA. Very interesting. Here we are talking about all these labs and how important they are. But what's my take-home message? What's more important? Looking at the patient. How about those virtual visits that people are talking about doing? So we're going to do virtual visits, so we don't even get to touch the patient. How many of your patients call and say, "How are my labs?" I say, "We don't treat this. We don't treat this piece of paper. We treat you." Right? With through the portal, how many times do you get a phone call? "Oh my gosh, my creatinine is 1.06. I got that yesterday. My kidneys are really taking a dump." The lab normal for that lab is 1.05. Are they taking a dump? Or is she maybe just a little dehydrated? But we get that every day, right? We get that, right, Gwen? We do, we get those. So 20% of our patients are diagnosed with RA and will continue to test negative throughout their disease. No, they're seronegative. That doesn't mean they don't have RA, but that means we had to use our assessment skills to diagnose it. And we're so good at that. You're right, I do hug and touch, because that's how we are. We feel, we look. When I start an IV, I say to a patient, "You're my bloodstreams. I'm shopping for that." And they love it. And they laugh, and they dilate, and we move forward. It's all good. It's all good. So seropositive, has a positive CCP, has a positive rheumatoid factor. But remember, with a positive rheumatoid factor, you can have anything else. You could have lupus, you can have mixed tissue. There's a lot of other things you can have. As Iris was saying in her article that from the last paper where she diagnosed somebody with RA, and then she found out that when she didn't get well, she said, "Gosh, what's going on at home?" And she said, "Oh, my husband has Hep C." She was like, "Oh, wait a minute, back up, start over." And sure enough, she was treating her, and she said, "Sorry, but I didn't know about that." So again, listen, look, and feel. Okay, so it's usually a more aggressive disease. It has more joint destruction. It has a higher tender joint count, swollen joint count. You're the new kid on the block. Keep touching, keep feeling, keep squeezing. ETA is it's a new lab test. ETA 1433 that's very predictive of RA. Anemia. Oh, the sharp scores are higher. I have a kid who came, and he's a kid, anybody younger than he's a kid. He's 29 years old. He's 4'10". He's had rheumatoid arthritis since he was 3 months old. He's 4'10", and his mother is thrilled that he weighs 105 pounds. He has major erosive disease. And I said to him, "How do you feel?" He said, "I feel terrific." As his hands, you can see all the erosive disease he's got. But he didn't have the benefits of the biologics then. It was gold and steroids. So his sharp score, his radiographic changes are high. So platelets, the higher the platelets, the more disease activity. We know that. Some of our patients take counts of 800,000, 900,000. And you worry about T, PE, oh my gosh, oh my gosh. But if they're seronegative, a lot of them, their CCP is negative, their rheumatoid factor is negative. We're going to talk about ANA in a second. 30% of them could still have RA, but gosh, how many times do you get a referral in your office just for ANA? Just for ANA. I have one girl who sits in my office. She comes every 6 months, and she sat with her legs cross-legged on the exam table. She wants the lights dim because she has photosensitivity. So at first she thinks she has lupus. She has POTS, post-traumatic stress syndrome. She's got all sorts of stuff. She has a long list. She brings it every time. She has Googleitis. She's not sick, but because of her positive ANA, she comes every 6 months and challenges us to diagnose what's wrong with her. We want to monitor the acute phase reactions and look at the active disease. So these are actually have to count, look at the patient, look at the joint counts. Cancel rate, which is more autoimmunity, and we use the CRP more because it's more for inflammation. Again, platelets are up, but it could be infection. How many times do you see your white count in your patients that's 14 or 50,000? Because of the flare. It's not because they have an infection, it's because of the rheumatoid flare. And the disease activity, their vectra, can be low. And we also have biologic vectors, MBTA, where we can actually monitor the patient's compliance with medications. So we have more and more labs. We have the advice for method. So we have a lot of ways to monitor our patients as long as we listen, we touch, and we take the time. How long does my doctor spend? We see 100 patients a day. It's obscene. How long do I spend with the patient? Much longer. So patients will say, can I have Nurse Jackie? Because she sits and listens to me and refills my prescriptions. He does come in and talk to the patient for a minute and sits down with his iPad and spends time with the patient, but it's very focused. It's very focused. It works. It sounds crazy, but it works. I don't know. I promise you I talk. Again, 1/3 of our patients who have a positive ANA have rheumatoid arthritis. But there are other things that go along with ANA. What's the most positive is lupus, right? Many who have lupus have a positive ANA. And there are other things that are positive that, like diabetes, malignancies. I wanted to quote Betsy. Betsy says, and she writes for Rheumatology Nursing Letters, it can send you on a wild goose chase. It's rarely a one-stop shop. And she's right, because the ANA is positive, and the patient comes in and says, oh my gosh, I've been referred to a rheumatologist, what's wrong with me? And so Betsy wrote that, I thought that was very, very, very good. The specificity of the SLE, or lupus, is 57%, but the sensitivity is 99%. So again, they could have a malignancy, it could be liver disease, it could be beta blockers. Oh my gosh, it could be pregnancy. Wouldn't you be surprised if it was pregnancy? So would you. So there are a lot of other things we have to do. Betsy's patient that she had in the paper, she talked about, yeah, she had very little positive rheumatoid, but her ANA was positive. She had Raynaud's, a positive Schirler's test. So she diagnosed her with Sjogren's, and then about 6 months later went, gosh, you've got tender joints problems, swelling, pain, morning stiffness. Maybe you have Sjogren's and secondary RA. How did that happen, that diagnosis? From taking the time to meet with the patient. And then she realized that little tiny rheumatoid factor was also a player. Okay, so there are many other proteins that are recognized. So all, and that attack was called inflammation. So again, the ANA can be positive for a lot of reasons, and those autoantibodies start that cascade of inflammation, causing the body to attack itself. We have markers. We have ESR and CRP, and we use those. Those we use to see how the patient's doing. Once you do a rheumatoid factor in the CCP, you don't need to repeat it. It is not a marker of how you're doing. It's and the doctors keep ordering it like to say, how's your rheumatoid doing? No. Once you're diagnosed, I want to know how your SED rate and your CRP is. Because once you have the diagnosis, we're going to re-diagnose the diagnosis. Now we need to look at ESR and CRP. Hi, honey. So we use that when we do our ultrasound test for our CDI and our SDI, because then we have a marker, we have the markers of inflammation, we have the CRP and the ESR, and we have the ultrasound, so we can actually look at erosive disease. How many of you guys do ultrasound in your office? Fascinating. We do ultrasound, so we get to actually look at how we're doing. We're looking because we explain the difference between RA and something else. Because they don't understand that the erosive disease is what we're trying to prevent. I tell them, Swiss cheese holes. I don't want Swiss cheese holes in your body. That's what we're looking for on ultrasounds, little tiny holes. So they are called acute phase reactions, and they represent an increase in serum proteins that accompany inflammation and tissue injury. They're not particular to any disease. So sometimes we can't distinguish between acute and chronic inflammation. What do we know about inflammation? We know watershed. Right, nurses? We know watershed. What happens when you have a stroke? If I do a CT on your head, are you going to see that inflammation right away? Or is that going to show up tomorrow? It's going to show up tomorrow. Are we going to treat the patient tomorrow because we don't see the inflammation? When are we going to do it? We're going to treat the patient now, right? Because the watershed isn't going to show up for 24 hours. Right? Hi, I'm Jack. So for us, it's important that we do acute phase reactions. And of the two, the CRP is more indicative. So let's look at the erythrocyte sedimentation rate. It can be influenced by the changes to inflammation because the cell changes in size and shape and the number of erythrocytes. How many of your patients have renal disease? All of them? How many of them have poor pump syndrome? How many of them have chronic renal insufficiency? Many, 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 many. How do you tell patients that this can be just directly related to chronic renal insufficiency? What does kidney make? Kidney makes erythropoietin. So if you don't have erythropoietin, that's going to change how the ESR is represented. So the ESR can be elevated from somebody who is older, define older, okay? Somebody who has anemia, because again, if you don't have red cells, you can't bind them. Patients with renal disease, because again, they're missing that erythropoietin, and obese patients, okay? Adiposity is a nice way to say a little bit, or as we say in our practice, under tall. So some of our patients are under tall. So I have a lady right now who all her labs are normal except a tiny bit on her rheumatoid factor. I went down with her yesterday. So on top of everything else, she has fibromyalgia, and her biggest problem is she's not sleeping because she has so much pain. And when I told her she had fibro, she just started. I have another disease and help everything else. Oh my God, oh my God. I said, if you just sleep, we'll be in a better place. So I'm working on sleep with her. But it's because of her, she's also 250 pounds, that her sleep rate's up. Okay, so C-reactive protein is a protein that's found in the plasma, and it's synthesized by the liver to respond to those macrophages and the fat cells. We just talked about those, adiposity, right? So levels can rise in response to inflammation, but it can also be an acute or chronic condition, like bacterial, viral, or fungal infections, any other rheumatic or inflammatory diseases, any kind of cancer. And again, we get calls all the time. How many times do you get a call about their portal and their labs? Okay, and you're like, okay, let's go back and look. So even CRP can go up with aging. And again, it's defined as anybody over the age of 65. Okay. So let's look at a CBC. Chronic diseases such as RA can make it difficult because the bone marrow is suppressed. And again, they get anemia and chronic disease. So let's look at RA for just a second. If I have anemia or chronic disease, do I have red cells to saturate? No. What two things decrease hemoglobin binding with oxygen? Fever and acidosis. How many of our patients have acidosis? Either from lung disease or renal insufficiency. So even if they have normal hemoglobin, they can't call it the Cook-Bank-Side deoxyhemoglobin association curve. Do you make cakes? Do you make cakes?
Yeah.
Okay. I always ask a man, on the back of a box of a cake mix, it says, add 2 eggs. Does it say add 2 raw eggs? No, it says add 2 eggs. Why? Because they assume you would not add hard-boiled eggs. And you're right. Because what would happen? Awesome, you guys. Awesome, you guys. So here we are. If I even had a normal hemoglobin, it wouldn't saturate with oxygen, and our poor patients are anemic. So they tell you all the time, I'm so weak. And the pain goes up, and their motor runs faster, and their saturation goes down. So no wonder they don't feel good. So we worry about their anemia, their hemoglobin doesn't carry oxygen the way it's supposed to. The hematocrit is the amount of percentage of red cells. And again, boys are a little more than girls. And we're that way in both red cells, hemoglobin, and hematocrit. So a CBC, a complete count. We learned in nursing school, the white count is up, it's leukocytosis. Well, what does that mean? I'm allergic to myself or I have an infection. There you go. Oh, well, that's unfair. Because I learned in nursing school, if the white count's up, you're infected, and if the white count's down, you have viral. And I was like, oh, wait a minute. You can have an elevated white count when you're allergic to yourself? Let me think about that for a second. And the answer is sure. So your white count can be up when you have a flare. So it's another marker of inflammation. So we have so many clues in addition to looking at just our vision. How about a platelet count? Again, we talked about that. Platelet count goes sky high. 1 million. 800,000. It's really high. Or if they're or a TNF drop really, really low. And they can get idiopathic thrombocytopenia, ITP, and their platelet count can go way down and they can develop bleeding restrictions. Like, oh, wait. So how am I going to know that? I have to do a platelet count. I did a platelet count on a lady last week. It was 9. Like, oh my gosh. Don't bump into anything. Go straight home, bubble wrap yourself, and go move. I'm happy to report to you that she did all those things, and she came back yesterday, and her platelet count was 2,200. Still not great, but better than 9. Way better than 9. Not great. I'm looking for 150, but I'll take 22 over 22,000 over 9,000. Okay. So other lab tests. Renal lab tests. We just their BUN is not normal because their pump's not working the way it's supposed to. And again, if their pump's not working the way it's supposed to, if they're fatigued, guess what? Oh, Chris, right on target. Perfect. Nobody knows but me. Okay. Depression. If they have depression and they're fatigued, they're fatigued. So seriously, sometimes just think their fatigue part of their management. I tell them when your motor runs faster, your compliance goes down because you're too tired to comply. You just don't want to take, you don't want to do, you just want to sit. Okay? Liver function studies. Oh my goodness. What things affect liver? Booze, methotrexate, anything over the counter, Tylenol. You know, if you can buy it over the counter, it must be safe. Right? Is that true? And how many patients are honest with you? I only have one beer a night. That means they have 6. If 2 beers a night, that means you really have 12, right? I had a patient with gout. I told him I don't want you to drink beer anymore. So his wife came in and she said to me, "Oh, Jack, you're going to be so proud of my husband. He's no longer drinking a 6-pack of beer a night. He drinks a box of wine instead." So it's much, much better. He's good. So, you know, you have to kind of read between the lines sometimes. But we have to make adjustments based on their LFTs all the time. And I have patients that are on drugs like Arada, Enduran. I mean, that you really have to watch what you're doing. Because we want to suppress the disease. We want to keep the flares down, but we don't want to suppress their liver into submission, right? So we really need to watch our patients. How about hepatitis B? All you nurses, we're inoculated, so our surface antigen. But how about surface antigen? We test for surface antigen. Do you know how many patients who are Korean, Chinese, Filipino, they're positive just because of their exposure in their country? I work for a practice where all of, probably about 20% of my patients, their last name is either Win or Wong. So, they're already, you know, surface antigen positive. And then we started testing for hepatitis B core. Because a lot of the studies, if their core is positive, they can't get the drug. Jen, do you have a question?
I'm actually eating, but I'm not going to eat till after I lunch.
Oh. Okay. Well, don't go. I don't want Okay. So, and then again, Iris was just saying the CDC recommends that if you were born between 1945 and 1968, that you should screen your patients for Hep C as well. So, I mean, we're constantly the vigilant one. And you know what, Iris? We had a patient we TB tested. We started her on TNF alpha drugs. She did really well for about a year, and then she got TB scrofula in her neck. I ran back to the chart and I'm like, wait a minute. Wait just a darn minute. We know we tested this woman. Yup, we tested her. She was TB negative. But her body didn't read the book. How many of our patients does the body not read the book? And sure enough, she got scrofula in her neck, TB. And you're like, wait a minute, that's just not right. But, you know, she's now back, you know, doing well, but we had to take a year off and get things squared away. But I was concerned that maybe I missed the boat, that I forgot to. We tried. We really do. Based on that, we try to screen every year. Not just once, but every year. I've been doing a quantiferin or a T-spot. Okay. How about uric acid? What do we know about gout? What do we learn in school? It's the king's disease. Yes, it's the king's. What does that mean? That means those people that eat red meat and drink beer and wine have gout, okay? What's really gout, only 10% of the patients who have gout is related to diet. 90% is related to underexcretion. Your kidney's not getting rid of the uric acid, okay? So there's underexcretion or overproduction. Well, then, what about a Sonoma? Would that help us? Oh, yes. How many times have you had a patient come in with a total knee replacement, and then you see a psoriatic patch on his leg, and you're like, oh, you didn't treat the cause of your knee problem. You have psoriatic arthritis, not a torn meniscus in your knee. Well, maybe you have that too, but we want to treat the cause. Stop laughing, but that's not right. But it happens so often. The patients are not treated. They come to our practice, they're on tons of medication, but they're not treating the cause of the disease. They're treating the effect of the disease. So if you look at uric acid, what are we looking at? We're looking at gout. Well, what else can we be looking at? So what if they have crystals in their knees? Are those uric acid crystals? Are those CPPD crystals? Pseudo-gout. So I actually have to aspirate the knee and evaluate it, because they're treated different. We wouldn't put somebody on Dispexa for pseudo-gout. So again, looking at the patient, listening to the patient, looking at the whole patient, doing the joint count, doing everything all together is what we specialize in. And our patients are lucky to have you guys, and you really are, because you're awesome. Okay, so let's put the pieces together. Here's a sample RA patient. Rheumatoid factor is positive. Anti-CCP is positive. No. ANA is positive. Sed rate, wow, off the top. CRP is crazy, really, really high. Hematocrit's 32. So even if it was a boy or a girl, that's pretty low. Hemoglobin down. Again, anemia, chronic disease, look at the white count. Does the patient have active disease? Very much so. And the CRP is really, really high. And the ANA is positive. Again, it doesn't have to be for rheumatoid. It can be a lot of other things. Sjogren's. It is more sensitive to lupus. Okay? Yeah, this is my little lady, although her CCP wasn't this high. Rheumatoid factor, not anything to write home about. CCP is high, and it's negative. Remember, you don't have to have a positive ANA. Third of our patients. Sed rate, 40. But look at the CCP. So that really shows inflammation. Okay? The hematocrit's 36, so a little low. Hemoglobin's low. If it was a girl, not too bad. White count's a little high. But this one doesn't make me go, oh my gosh. But then if I look at the patient, and her joint count's 12 and 14, I'm like, oh my gosh, she's really sick. So we don't treat the paper. We treat the person. Because that's really what we do. So, questions on labs before we do hard questions? No questions on that? It was that easy?
You just explained it.
Huh?
You just explained it.
Oh, thanks. I think when we do labs, it's just a part of what we do. It's more important what we touch, we see, we feel. And you being in rheumatology 6 months, you will learn to trust your assessment, to learn how to assess, to listen to the patient, to find out things like, oh my gosh, the reason you're not getting better is because you really don't have rheumatoid, your husband had hep C, and here we are. Or as Betsy said, you know, it's nothing is one-stop shopping. The ANA being positive doesn't really, it's just, for us, and 10% of your female population has a positive ANA. And nothing else. Even though we are obligated when we come in with a positive ANA to look at a lupus panel to look at a rheumatoid panel. And we do that because we want to make sure we're not missing anything. If their labs are positive, oops, pardon me, oh my gosh, and they don't have disease presently, we tell them, please come back in 6 months. And let me just look at you. Let me just look at you. And this is what we're looking for. We don't want to scare you. And they tell me, you know, mom's had it, da 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 da, and I'm like, okay, I'm not writing you off. I still want to see you. Come back in 6 months and let's just keep an eye on you. Because you know, many things that could change. Rheumatoid is very positive. Cold weather, well, in California, we don't have cold weather. But I oftentimes call Scott and say, so how is it the snowy world over there? Because our patients, when it's cold, it's 50. I'm so stiff and it's raining. And how much is it raining in California? 5 inches a year if it's a lot. Not like Seattle, right? But they don't feel good because it's cold. So again, looking for disease flares, looking at the elements in their family, it all plays a part in what we do. And you guys are awesome, awesome. Okay, so we're going to ask a couple of questions. You have a little keypad. Do you want to do those now, Scott? By the meeting?
Yeah. We'll also get a. So everyone should have a keypad in front of them. If not, raise your hand, we'll get you one. And so this is just an audience response system. There's little buttons on there. She's going to ask a question, and you'll see the answers.
And there's no wrong answer.
There's no wrong.
That's right.
There's no wrong answer. So you guys that have just walked in and you're like, oh gosh, I don't know anything about this disease and I don't want to push that button. And no. And there's no door 1 and door 2. And he's not Mikey Hall and I'm not Anna, so you don't have to worry about that.
Close.
Okay, close. Okay, you're Monty Hall, but I'm not Anna. Okay. All right. So the question is, disease from? Whose fault is it? Did you get it from your mother or your father? If there's a reason, were you a smoker? Is that the reason? Is it just bad luck? Or we really don't know what develops for different reasons for different people. So is it A, B, C, or D? Do we have music?
We gotta get Jeopardy going.
So we get 10 answers? So I push the pointer stuff?
No, just go ahead, just hit forward.
Okay. And everybody, and that's right. There are different reasons. Smoking increases inflammation. True. That's true. Smoking does increase inflammation. Does it have a genetic tendency? Yes, that's also true. Is it bad luck? Yes, that is also true. I had a father who came in with a gun because he was going to kill the person who had given his son. All right. Seriously. And he was looking for that person. He's still looking. He's still looking. Thank goodness.
He's still out there.
Yeah, but oh my goodness. He was pretty angry. This kid was a track star, and all of a sudden he couldn't walk. So, is there a cure for RA? No, there probably will never be. No, but once we refine it with the use of biomarkers, there will be. No, but we can try to halt the progression of your disease. Or D, yes, our therapies are as good as a cure. So mark your keypad. We got more responses. That's awesome. Our population grew. And you're right. We are looking for a remission. So biomarkers, we're getting smarter. They're adding more lab tests. Right? Gwen's laughing again. What's ETA? That came out and I was like, what's ETA? Oh, that's for rheumatoid arthritis. Rock star. I love it. One more lab test. We just keep getting smarter. Our DNA markers just keep getting smarter. So, yes, it all helps us with that diagnosis. which is what we need. Is RA going to affect my life expectancy? Yes, your risk of death is 75% than the general population. B, your risk of death is 40%. C, no RA patients just live as long as the general population. Or D, it's hard to predict an individual's life expectancy. So what do you think the answer would be? A, B, C, or D? No, one person not wanting to vote. There we go. Okay. So you're both, all of you are right. Okay? You can have early coronary disease. And I wrote about that in several of the rheumatology nursing letters. The inflammation you see here can also be in your coronaries. So your risk of coronary can be greater. It's hard to predict. There are many other things. Many of our patients don't just have rheumatoid arthritis. They have other things that go with it. We talked about it. Renal insufficiency, cardiomyopathy. Many of our patients have more than one disease. So it's hard for us to predict. So it's kind of all of those. Yes, you do have a risk. You do have a higher, and that's even more why I empower you to treat the whole person. Don't just look. I mean, everything now, Chris, is so segmented. They see the heart doctor. They see the lung doctor. They see endocrinologists. Do all the doctors sit down around the table and talk about the patient? No. Who does that? We do that. We're the only one who coordinates their care. So fasten your seatbelt. That's what we do. So for us, we're trying to make this less risk. Are my children going to get right? Oh my gosh. There's a 50% probability. There's a 25% probability. No, not unless they're around smokers regularly. You know, that's a kid's trick. I'm not smoking, but I was around somebody who was smoking. Or D, there's no apparent genetic link. Two more people? Two more people? Somebody doesn't want to vote? Still thinking? One more? Pushing me here. Okay, and you're right. There is a genetic, it's an HLA gene that's genetically predisposed. It's kind of like diabetes. You know, that diabetes is genetically linked. The exact percentile, we're not sure, we just know it's genetically linked. And we said diabetes. Okay, so you're right. So we're not quite sure, but we think probably B is more the correct answer than the rest of them. And again, we're working on that HLA allele, trying to figure it out. And there's lots and lots of research. So keep tuned in, because as fast as RNS learns, and that's what people say to me, when are you going to retire? And my answer is, when I stop learning. With you taking care of patients, I just keep learning from you every single day. And I thank you for what you do, because you're all my teachers. And I thank you so much for that.
That was awesome. So we're at 12.
Huh?
We're at 12.
Oh.
Okay, I'm going to introduce myself. I'm Iris Zink. I'm the president of the Rheumatology Nurses Society. Where are you going to go?
Not in front of you.
Yeah, please do.
Okay.
Just don't break my placenta. Okay.
I won't.
So I'm the current president of the Rheumatology Nurses Society. I'm from Michigan. You have no idea what cold is like, okay? I just got married, which is super exciting, to a nurse practitioner. And this is obviously our second marriage, but we have many children, so it's really, really awesome. There's the Association of Women in Rheumatology conference, and Chris and I took 7 children with us to the conference and drove from Michigan to Hilton Head. So, you know, he was a keeper. We knew right then he was a keeper. He used to manage 150 nurses at University of Michigan Hospital, so I knew that he could take care of all the children well. He could take care of all those nurses. I've been in rheumatology for 15 years. So Chris and I were moving in together about, I don't know, 3 weeks ago after the wedding, and everything was all settled. And it was snowing in Michigan 3 weeks ago. So you can only feel bad for us there. We know real cold, and our patients are constantly flaring with the cold weather changes, which is hilarious because I lecture all over, and I gave a lecture many years ago in Arizona, and we talked about weather changes and how that impacts the patient's disease state, and they were all looking at me blankly, like they had no idea what I was talking about. So you just have to know your audience. So I've been a rheumatology nurse practitioner for 15 years. Before that, I worked at the local county hospital. That's where I met my first patient who had rheumatoid arthritis. She was a 54-year-old lady who had rheumatoid arthritis. She was ventilator dependent at the time that I met her in the intensive care unit. My report said, I talk really fast because we're from Michigan, it's really cold. Hi, how you doing? Okay, bye. This is where that comes from. So sorry about the fast talking. And it's 10:30 at night my time. You gotta have a 5 a.m. to get here. So have another glass of wine. It'll get better. So where was I going with that? Oh, a 54-year-old Mary who was in the hospital who had rheumatoid arthritis. So in report they said she has rheumatoid arthritis and she's on the ventilator. And I went, okay, there's going to be more of the story here, right? So I went to Grand Valley State University for my nursing. I went to Michigan State University for my fashion design degree. Jackie fixed me, so I was stressed. The hem was completely gone, but Jackie's a really good nurse, so I'm all fixed temporarily. Thank you for Jackie for fixing me. So don't notice the backdoor skirt, I think just go with it. So I am taking care of this patient, and at Grand Valley State University, the only thing we learned about rheumatoid arthritis was it was the one that deformed you. That was it. That was the extent of my rheumatoid arthritis education in nursing school. Not uncommon, as we travel around the United States. It is not an uncommon state. So I learned that it was that Mary had pulmonary fibrosis secondary to having advanced rheumatoid arthritis. And back in 1991, when I was taking care of Mary in the intensive care unit, she had been on gold steroids, gold, injectable gold. You all are maybe new to rheumatology, don't even know that people gold. I still have a couple patients on injectable gold. It's sort of illegal because my patients get it from Canada, canadadrugs.com. Thank you very much for Canada. And they get it shipped to the United States, they bring it to our office, and we still administer it. The funny thing is the doctor that I worked for 15 years won't sign the prescriptions because she doesn't want to go to jail. So I signed the prescriptions because I'm not worried. My sister's a deputy prosecuting attorney, so we're good. She said, I'm not going to go to jail for writing prescriptions for gold for something that's very efficacious for our patients here, so we're okay. So that was the first patient that I came into contact with rheumatoid arthritis. She did die in our intensive care unit at age 54 of complications of rheumatoid arthritis. So she had pulmonary fibrosis. Your lungs, your lungs are supposed to be elastic, like rubber balloons, right? The blood permeates the tissues and allows the oxygen to get into your bloodstream. That's how this whole thing works. With rheumatoid arthritis, the tissues get fibrous, like brown paper bags. That's why we listen to our patients' lungs every single time they come to the office. The patients often say to me, the only reason you listen to my lungs is so you can charge my insurance more. And I say, no, actually, rheumatoid arthritis, as I've explained to you several times, and we're going to do it again today, can affect your heart and can affect your lungs, and we want to make sure that that's not happening, and that's why. So it's certainly an education piece. So Jackie did a phenomenal job of talking about the labs. I'm going to talk about the drugs that we have available. Because coming into rheumatology 15 years ago, I was frequently writing prescriptions for wheelchairs, walkers, and inhalers. My patients were oxygen dependent. I have a hand fetish, so I took pictures of all of my patients' hands because I think hands are really, really beautiful. And you can define the disease by the way the hands look, which is really, really interesting to me. So I had a student every single day. Chris was actually my nurse practitioner student. Worked out well for me. So, it's a true story. So I have an intern, a resident or a medical student right next to Michigan State University, and I'm the only person in town who takes students. So I take students every single day. So I have this book of pictures that I show my students. It's very hard for me to show my students the book of pictures because all the patients in the book are dead from rheumatoid arthritis complications. They used to die. Jackie knows they used to die. They used to have heart attacks and they used to die really, really young from rheumatoid arthritis complications. Now the patients look like us. It's amazing. They're young, they're healthy, they do sports, they're very physically active because 90% of our patients with rheumatoid arthritis get into remission with these drugs that we have. It's like HIV. When I was in fashion design, all my friends died from HIV back in the 80s. Now it's a chronic disease. It's just amazing in that short of a time span that things can change and evolve so quickly. So that's why it's so cool to be in rheumatology, because not only is it immunologically stimulating, and we're going to do a free immunology boot camp, as Kevin said, and free was the word that Chris wanted me to say, and free immunology boot camp, so we can really all learn about the cytokines and what's really going on in our bodies. It is so interesting and exciting, but it's also a time because the drugs are so awesome that we have to treat these diseases. So we're going to go kind of fast because I talk sort of fast. So this is how I explain rheumatoid arthritis. So for whatever reason, an alarm goes off in the joint space, okay? We don't know why. It's an autoimmune disease. So an alarm goes off in the joint space, and your body sends in a T cell to figure out what's going on. Your paramedics, your T cells, right? So they're going to go in there and figure out what's going on. But these particular T cells that got sent into that joint where the alarm was going off are new on the job. We're going to say they just on orientation. They're new T cells, okay? And so when they get in there, they are so mortified by what they see in the joint space that they actually vomit, or they secrete more pro-inflammatory cells. So instead of the memory T cell remembering the good guys from the bad guys, they all get dysfunctional. The T cells and more of these pro-inflammatory cytokines into the joint space. This whole pannus forms. So the joint space gets all thickened and inflamed, and that's why the patients tell you that in the morning they feel so stiff that they can't move. They're like a tin man, because there's way too much cellular activity with every single one of their joint spaces. And it's very, very symmetrical. Patients will tell you that they can't get a creep because it's both hands, both wrists, both feet, both ankles, both knees, both shoulders, and it can rotate around. My patient told me the day that she got diagnosed, which I thought was wild. I was seeing her for osteoarthritis, and she said, you know, the strangest thing happened the other day. I was laying in the bed because I just didn't feel good, and both my ankles hurt so bad, and they were swelling, and it was just crazy. So she said, I laid there, and then both of my shoulders started to ache so bad, I thought I was going to cry. So I got up and took some Aleve, and I went back to bed, and the next morning it was my elbows. It was in my elbows. Both of my elbows were so painful. I said, we're doing some labs on you, and sure enough, her CCP and her rheumatoid factor was all positive. She told me that she got rheumatoid arthritis. It sometimes happens like that. They know. They just don't feel right. So normal joint space, thickened, lots of inflammation going on in the rheumatoid arthritis. Jackie said we're looking to prevent Swiss cheese. I'm a picture kind of a girl, okay? So an erosion. So we're saying to the patients, oh my God, you have erosions in your joint space. Like Pac-Man took a bite out of the bone. That's what we're trying to prevent with these biologic drugs or the disease-modifying drugs. Okay, we're trying to prevent this. We don't know if you can get this back. In the old days, I would say, you can't get this back. Now, some of these drugs are so amazing, maybe we can get it back. We don't know. But the point to prevent this erosion from occurring, because that's what causes the drift. As the bones no longer articulate straight on each other, so they're not articulating this way, then you can have ulnar drift, and the patient's hands can deviate, and that's where the deformities come in. So that's what we're trying to prevent. So diagnostic criteria for rheumatoid arthritis, greater 4 of the following must be present. Morning stiffness, Jackie talked about that. More than 3 joints involved. Symmetrical, we talked about that. Rotating joint pain for up to 6 weeks. Positive rheumatoid factor, although some of the patients will not have a positive rheumatoid factor, she talked to you about that. Erosive changes, we told you what that was, and possibility of rheumatoid nodules, where they actually get soft tissue nodules right over the joint space. So there's a treat to target, and that just basically means constant surveillance on your patients and how they're doing. So treat to target is sort of a guideline that says that you really should be following up with your patient every 3 to 6 months minimum. 1 to 3 would be ideal to see how they're doing on their drugs so you can switch them quickly so you can get them into remission faster. I always pontificate about this, that Europe does a much better job. Predominantly the nurse-run clinics. So in Europe, the whole setup is if you suspect that you have rheumatoid arthritis, you are sent to the nurse-run clinic, yay for us. The nurses do all the preliminary labs, x-rays, examination of joint count. Don't let your doctor tell you that you can't do a joint count because you're a nurse, you should. Okay. They do all the preliminary stuff. If the patient has rheumatoid arthritis, they're rapidly progressed into rheumatology where they're put on treatment. So patients in in Europe tend to get in remission and stay in remission better because 6-month wait list to get in. So the longer the treatment is postponed, the harder it is to get the patient into remission, the more damage that occurs. We always talk about, Jackie and I travel around quite a bit, and it is upsetting to hear what the rheumatologists do in this United States. But some rheumatologists tend to wait a really long time to put patients on biologic drugs, and some rheumatologists also take their patients off biologic drugs if they think they're going to get pregnant, which is backwards, but we can talk about that later. So, you know, how much deformity is too much? If you have a piano player and you lose a finger, that's too much, okay? So any level of deformity, I would say, is too much for these patients, because it may just be one finger to you, but to a pianist or a guitar player, it's a great. So we were trying to prevent any kind of deformity. So joint counts, I do these all the time. I tend to be very, very gentle, too gentle. There is a glove coming out that is going to tell you to apply 20 pounds of pressure so that we're all using the same standard, because right now that's the problem with these measurement tools, is that we're all using our own measurement tool. Thank you. So you just go right over the PIPs and the MCPs, so the knuckles right here, and I'm going to squeeze, and she's going to say, ow, if it's tender, and I'm also feeling for sponginess. But I can tell my patients when I get there, I say, okay, I'm going to go squeeze all your joints. If there's anything that you don't want me to squeeze, let me know. Because I just ask in advance, because I don't really want to hurt them. That's not my objective here. Our objective is to document what is swollen and what is tender. So you get a tender and swollen joint count. We talked about complications of untreated already. This is my married patient with a pulmonary fibrosis where the lungs have gotten stiff on the bottom. So pulmonary fibrosis, disability, deformity, decreased quality of life, increased morbidity and mortality. There's still about a 10-year life expectancy difference, but we're seeing that evolve and change. The biologics are more commonly used. Rheumatoid arthritis can affect many, many organs. We've just been through that. Don't forget about that. The patients tend to think that it's just a joint deforming disease, but it can affect your liver with Felty's disease. It can affect your heart. It can affect your lungs. It can affect your eye. You need to know that. 2015 ACR guidelines for the treatment of rheumatoid arthritis. Certainly, it's about treating the patient aggressively, trying a disease-modifying anti-rheumatic drug. We'll talk about what that is. And if you're not getting any response clinically and the patient's still escalating, then going to a biologic or add-on DMARD therapy as quickly as possible. Again, the 2015 guidelines just enabled us to use pretty much whatever we want. It's very, very nice for me now. I tend to use Orencia a lot first line in my older patients because the safety profile is so wonderful. So now I can write to the insurance company, I'm not using a TNF for ACR guidelines, I can use this drug first. And so the ACR guidelines has allowed me to use that to argue with insurance companies about that I should be making the decision on what drug the patient's on, not necessarily the drug companies. It doesn't always work for me, but I'm a bulldog and they don't like to argue with me. So ACR guidelines, again, TNF failure, you're going to go try to another biologic. It's basically just a decision tree or an algorithm about treatment decisions to make with your patients, using the oral drugs and then escalating to the biologic drugs or the small molecule drugs if you're going to use the JAK inhibitor. So clinical pearl, Jackie already covered this. I have had patients who had Hep C that I thought had rheumatoid arthritis because I was told they had rheumatoid arthritis. Go put that patient on methotrexate. They have rheumatoid arthritis. Okay, pick up the chart. Well, in the old days, pick up the chart, go talk to the patient. The patient didn't have rheumatoid arthritis. They had hepatitis C. HIV can also make your rheumatoid factor positive. So you need to make sure that you're treating what you think you're treating. So, anti-inflammatories. There was just an article that came into my email today that 50% of your patients don't know what an NSAID is. They're using them over the counter. They still don't know what an NSAID is. They don't know. You use the word NSAID, we need to say pain medications or anti-inflammatory medications. I use the names Aleve, ibuprofen, Motrin. What are you taking? How much are you taking? And oftentimes my patients are taking that in addition to the Moxicam or Nabutone or the Celebrex or whatever I have them on too. And they don't realize that these are both NSAIDs that they could be having gastrointestinal upset from them. So just being aware, it's really old. It's now expensive because of, you know, the FDA and badness. But colchicine, I still use it with stuff. I still use it, I was trying to be politically correct.
That's why I was laughing, I'm sorry.
It was a clinical trial problem. But colchicine is great, and I still use it on my patients who are on Coumadin. So it's a little iris trick. You have to very, very closely monitor them. But colchicine is an anti-inflammatory, but it is also an anti-gout, or it helps both things. So that's kind of my little surprise trick. Have you ever done colchicine? Oh no. Okay, let's try that one. Disease-modifying anti-rheumatic drugs. So I go around and teach about rheumatology to state rheumatology nurses or state nurse practitioner associations, the Michigan State Rheumatology or Michigan State MIC Nurse Association. And generally I dress up like Scarlett Johansson, that's a whole other talk, because it's easier to explain things when you're dressed as a superhero, I think, but it's the biologics are the superheroes of rheumatology. So if the biologics are superhero, what is your shield? Or your superpower, or your sword, or whatever. That's the disease-modifying anti-rheumatic drugs. I always explain this to the patients. So Remicade works well with methotrexate. All of your biologics work better if you're pairing them with a disease-modifying anti-rheumatic drug. Statistically, most studies show that they work better collectively. Some patients can't take disease-modifying anti-rheumatic drugs because they're going to get pregnant, or they have fatty liver disease, or they're an alcoholic, or they have an intolerance, or they have gastric bypass and they can't absorb the pills, and so you tried sub-Q and they still can't do it. There's reasons why patients can't tolerate the disease-modifying anti-rheumatic drugs, or they just won't take them. And we have to go to monotherapy, but statistically, most of the drugs work better if they're paired together. Also, your body's always trying to make antibodies against the drugs, right? So your body's more confused if it's trying to make antibodies against two drugs at the same time. And sometimes I try to explain that to my patient. Your body can figure out how to make a defense against Humira, and it can stop working. But if you're taking Humira and you're actually taking your methotrexate too, then it's more confusing to your body. Your body's letting antibodies against the medication. Very good. What's a TNF inhibitor? What's a B-cell inhibitor? So we have this whole toolkit now that we can use to treat rheumatoid arthritis. And these are the questions that we get, and they all just work differently. I was at this super cool conference because of Kevin. I was at the super cool conference in New York. It was the Interdisciplinary Autoimmune Summit. So it was rheumatology, GI, and dermatology, believe it or not, all in the same room. Shocker, I know. It was amazing. So in the old days when the biologics first came out, we were all like, well, you can't pair them together, right? The insert says you can't pair these biologics together. At the Autoimmune Interdisciplinary Summit, IAS. Right. At the IAS, they were talking about pairing the drugs, which was so awesome because now we have Prolia, right? So Prolia works on osteoblasts and osteoblastic activity, but it's a biologic, and you have patients who take Enbrel and Prolia, and hey, they're not super suppressed with their immune system, and they're still doing okay. There's a study where we use Rituxan and Humira together, adalimumab together, and it's still okay. The patient's still okay. So why are we treating Sally with a TNF, and we're treating Judy with a T cell, and we're treating Rebecca with a B cell, when we can use one drug that has a little bit of everything in it, and that's them. So I'm reassuring my patients, because you do have a handful of patients that are still not in remission. Wait, we're almost there. We're getting so close to a cure, it's ridiculous. But the new drugs that are coming out are even going to be more exciting. AbbVie has one in the pipeline that is a 17, interleukin 17 and TNF mixed, which is just super exciting because Cosentyx, for psoriatic arthritis is 17. So what happens if you pair it with TNF? How close are we going to be to remission? It's really an exciting time. So here's my biologic table. This is what I use to treat all the drugs and how they're dosed. So, 90% of them are either IV or subcutaneous. The JAK inhibitor, which is Xeljanz, is the first pill for rheumatoid arthritis, which I've had great success with. It's been pretty amazing with my patients. I'm super skeptical. I'm just old and grouchy, and I don't use the drugs when they first come out because I don't want to kill my patient. And unless the patient's tried everything and failed everything, I just would rather let's just let it sit on the market for a second. I was in the days Vioxx, okay? I've been there, all right? I remember that whole day when we had to change every single patient's anti-inflammatory in the office because Vioxx was taken off the market. It was a really awful thing. So, I'm a little slow to warm up, but I had a patient who was literally going to hospice in her late 50s because of her rheumatoid arthritis, and she wasn't about to take 90% medication. She told me that. Never was going to do it. Wasn't going to do it. So I had these pills in the sample closet. I said, there's a new pill for RA. Would you try that? I said, sure, I'll try that. So she came in the next time with her walker, but I walk in the room, she's like, that shit you gave me was awesome. Nice. We were seriously sitting here at hospital. She's on oxygen. She has a 40% ejection fraction, like 30, 40, like high 30s%. She was not doing well at all, but on Xeljanz, her disease activity went dramatically down. So it's not one shoe fits all, for sure. This is where the trust comes in, and this is where the nursing really comes in. Because the patients have to trust you that you're going to try another drug that's going to fit them. I tell them they're all purses, okay? It's like Coach Gucci, Michael Kors. They're all purses, right? But some purses fit some women better than others. It's like shoes or Merrell's, okay? We just have to keep trying the drug on until we get the one that fits you the best. And hopefully someday we'll have drugs that have multiple drugs in them, and so that'll be a much better fit, and it'll decrease inflammation more rapidly. So this is what we have so far. They have many indications. A lot of them do. It's hard to keep track of all this, which is so cool. While that RNP newsletter has that tear out, so you can paste that on your wall and keep track of what is what and who was with who. Contraindications. We're going to do a contraindications question mark of biologic drugs because we're still learning. So in the old days, we didn't use TNFs with patients who had lupus because maybe it's going to turn the lupus on. Again, probably still a good idea to be very cautious, but I've seen all kinds of things done. Tuberculosis, for sure. Your TNFs, there's a black box warning on tuberculosis, and so that's why we pre-screen all of our patients to make sure there's no active tuberculosis in this patient population. Active infection, again, still very controversial. So by and large, we stop the patient's medications when they have an active infection, but I do have patients who have foot ulcers, and they tell me that they started a biologic back up, and I'm like, oh my God, I hope that's not infected. And the ulcer seems to clear up a little faster. Because if you think about it, if you're pulling out the inflammation, the body's gonna heal faster. So the Rheumatology Nurses Society is putting a position paper out on perioperative care of the rheumatoid arthritis patient, because so often these drugs are stopped way too prematurely, and the patient's inflammation rises and they're flaring and their cardiovascular risk goes up 6 times after surgery. And I have said to more than one surgeon, you're trying to kill my patient. I had a patient who has really rheumatoid arthritis, who has gastric bypass. Her plastic surgeon and her hernia surgeon made her stop her biologic and methotrexate 6 weeks before surgery. She couldn't walk. She came in and I've never seen her that bad before. And he said, well, I'm not going to do the surgery. So she went with it. She went off of her medications for 6 weeks, but I said, she's going to have your fault because you let her inflammatory levels get up so high. So again, question, should the active infection, should they be on biologic or not on biologic? I had a patient in intensive care unit the other day who was going on the ventilator because his pulmonary infection was so bad, and his pulmonary inflammation was getting so worse, and Chris is like, well, he's been off his Humira for 6 months. Did anybody think about restarting that? Do we know if he's really infected, or is his lung disease because his rheumatoid arthritis is so poorly controlled? So our thought processes about that are changing. Patients who have hypogammaglobulinemia, I'm telling my patients all the time, I have daycare ladies that take these drugs. I have school teachers that take these drugs. We have patients who work with people in the public all the time. You're not going to get sicker than you do now, but when you get sick, you need to treat it very aggressively. And so patients who are taking an antibiotic 2 or 3 times a month may not be the right kind of patient for these types of drugs. You might be better off with orals. But again, if their level of inflammation is better, maybe they're going to be healthier. Hepatitis B and C, and then demyelinating disorders, again, is a big question mark because there was some concerns in the early trials with the TNF inhibitors about demyelinating disorders. But again, women get MS in their 20s and 40s, and women get rheumatoid arthritis in their 20s, 40s, 60s, and 80s. So, it could have been a population crossover for very unlucky women. So, I have put a black box on there to make you think about black box warnings, right? I'm very visual. So TNF inhibitors, black box warnings, certainly TB, bacterial sepsis, fungal infections, lymphoma, and other problems have been reported. So this is one of the patient questions that you're gonna get all the time. So statistically, patients start a biologic, and then within 6 months, they stop the biologic. Why does that happen? So the patients start a biologic drug, and then they feel better, and then 6 months later, they listen to a commercial on Humira, and then they stop the biologic, or they sit next to some lady in church, or their pharmacist, which happens, or their ophthalmologist says, I wouldn't be on that drug, that's way too powerful, that's like chemotherapy, why are you doing that to your immune system? So somebody trying to be helpful to the patient says some horrible thing about the biologic drug, and the patient gets scared and stops taking the biologic. Mostly because they hear about the cancer. That's the biggest concern. So I'm a Michigan State University Spartan. So we're gonna put 10,000 people in Spartan Stadium just for my nap. And it's now, like 11 o'clock at night. So 10,000 people in Spartan Stadium. Statistically, 2 of those people are gonna get lymphoma. Just statistically, okay? We're gonna put 10,000 people in Spartan Stadium. All of them have rheumatoid arthritis. 4 people are gonna get lymphoma. 10,000 people, Spartan Stadium. Everybody has rheumatoid arthritis and everybody's on a biologic. 4 people are getting lymphoma. Didn't go up, okay? I want you to tell your patients that. Poorly controlled disease increases your risk of lymphoma. The less well-controlled your disease is, the more likely bad things are gonna happen to you. Pulmonary disease, I met this crazy person, her name was Iris, she talked about 54-year-old people dying before these drugs came out. Bad things are gonna happen to you if you don't have your disease well controlled. Your cardiovascular risk is going to double if you don't have your disease under control. So we need to scare the patients about the disease, not the drugs. Okay, we need to educate them and inform them, but also make them aware that not treating is bad. My doctor that I work with is 73 years old. She's been in rheumatology for a really long time. She's awesome. And she says to the patients, if I told you you had lymphoma, you would say, where's the chemotherapy? It's the same diagnosis. If I told you you have rheumatoid arthritis, you would be asking me for treatment, because rheumatoid arthritis is as lethal as lymphoma left untreated. So that's why I explain this. Orencia, no black box, okay? Actemra interleukin 6 inhibitor, black box. Pregnancy category C. Rituxan pregnancy category C. Again, risk of infections mostly. Xeljanz pregnancy category C, risk of infections. Same. These are some of my patients. Mary's had 7 hand surgeries. Badly, those are all rheumatoid nodules. This baby is she's got some adherence problems, which is evidenced in her hands. She really just does not like to stick with the drugs. Again, Barbara has really been more scared of the medications than she has been of the disease, and so this is very, very evident in the deformities that we see. Everybody really feels bad for Judy, but she was working at the hardware store about 3 years ago. I mean, she has no MCPs left. These are all completely eroded. There's just full-on joint space in there. There's no joint left to speak of, but she could still get money out of the cash register. Again, I read very, very deformed thumbs. So this is what we're trying to prevent. So here are the hard questions that our patients are asking about rheumatoid arthritis medications. Will I need this medication for the rest of my life? The important thing is that we don't take away their hope. So the patients say, is this disease ever going to go away? And I always say all the time, we are so close to a cure. We are so close to a cure. I'm hoping in my lifetime we'll see, but we don't want to take away their hope. So will I take this medication for the rest of my life? Probably not. Once we get your RA to remission, we'll safely taper you off therapy. Probably if we were in Europe, if we got them really early. Probably there's some evidence of drug-free remissions, but that is limited to a select group of patients. Or C, sorry, but yes, rheumatoid arthritis is a chronic disease that typically requires lifelong medical management. Who did your answer? There is no wrong answer to this question. But we are collecting the data, so we really appreciate answers. Okay. So 73%, sorry, it's a chronic disease. You're probably going to have to take your medications. We do have patients that go off their biologic medications because they can't afford them, they just get tired of taking them. And it is kind of shocking when they stay in remission. They're like, hey, that worked. That was really, really good. It's even cooler if they stay on their methotrexate or they stay on a little bit of something, but sometimes they can get off their biologics. Most of the time, they can space them out more if they do really, really well. So they don't have to take it as frequently, but that is enough to keep them in remission. What if I want to get pregnant? That's fine. None of the drugs we typically use to treat RA are incompatible with pregnancy. that's fine, but we may have to adjust your treatment, especially if you're taking methotrexate or leflunomide. That's fine, but you'll have to stop taking all your medications that you can currently control your RA. And D, it's a bad idea, you shouldn't get pregnant.
Drink it there.
Stand right there. It's like the easy one.
Okay, are your votes in? No, good. That's fine, but we have to address your treatment. So, this is super interesting. I am really not politically correct at all, which is Kevin's working on, because I'm the president. But when my patient's taking methotrexate, I say to my patients, you can't get pregnant. And then I say, you can't get pregnant because if you do get pregnant, your baby's going to be seriously deformed. And I mean by deformed, your baby's not going to have arms and legs. I say that, okay? But I'm not very nice. All right, I tend to go right to the death. There's friends that say, you can't get pregnant on methotrexate. Guess what? Their patients thought they couldn't get pregnant on methotrexate. Like it was impossible to get pregnant on methotrexate. You have to be careful about the words that you use. Shouldn't get pregnant. It will be a really bad idea to get pregnant. The baby can have multiple deformities if you get pregnant. So we have to be careful what we say. Leflunomide is the same way. It's a fabulous drug. I love the drug. It really helps to get the patient in remission, but 2 years before pregnancy, it's a no-go. So, you have to be careful about what we're using. The biologics are great. There are fertility clinics in this state, in West California, that help patients with RA get pregnant using the biologics. So, I mean, biologics are good because if you have a level of inflammation, you're going to continue to abort. You're not going to be able to carry the pregnancy. And so you need to have your inflammation under control so you can carry the pregnancy.
Well, there is, if you're pregnant, you make more steroids.
Yes, which is good. You might go into remission. That looks amazing. Okay, am I getting cancer for my biologic? Hopefully I answered this question. You have a 50% greater likelihood of developing certain cancers than a general population. You have a 25% greater likelihood of developing certain cancers than the general population. It does not appear that biologic therapy adds to the normal background risk of cancer in patients with RA. And we don't really know if RA impacts the risk of developing cancer. Again, no wrong answers, please just put one in. 6. You're so excited about dessert, you can't even vote anymore.
Yeah, you're not allowed to take a spoonful of dessert until this presentation.
Greatest glucose essential chemist.
It does not appear that biologic therapy adds to normal background risk of cancer in patients with RA, but there is an increased risk of cancer in patients who have autoimmunity. So you have an increased risk of lymphoma if you have an autoimmune disease, but the biologics don't seem to be making that worse. Are there herbal supplements or we are in that state, aren't we? I'm on rheumatoid arthritis with my turmeric and my cherry juice, and I'm on my naturopath, which is fine, but let's vote. Absolutely not. Many herbal treatments may actually make you feel worse. It's unlikely to hurt. Yes, there are some herbal treatments that have been shown to help. So what is the correct answer or the answer that you'd like to put in? 5, 6, 7. Okay, you really want to eat that dessert. So 55% B. While it's unlikely to hurt, there's no compelling evidence that herbal supplements are effective in treating rheumatoid arthritis. Yes, there's some herbal supplements. So my doctor is wonderful. We use dry tart cherries, we use cherry juice, we use glucosamine. That's all cool. Any kind of natural anti-inflammatory diet I'm totally down with. That's all great. NutraSweet is the devil. Okay, so things like that are very, very helpful. But it has to be in conjunction with, because the herbal supplements are not going to, again, prevent lymphoma or cardiac or pulmonary disease from rheumatoid arthritis. We did it. That's awesome. All right, so we got
We had a question come in because we are live streaming, and
great.
as you now replay everything you just said.
Great.
Every drug mentioned. Yeah.
Yes.
Scott, do you remember what the question said?
So the question was, what is the prevalence of RA in patients with type 1 diabetes?
Yeah, so it's the prevalence of RA in patients with type 1 diabetes.
I don't know the exact statistic, but I did a presentation on women and autoimmune disease at the Michigan Nurse Practitioner Conference, and Women who have autoimmune disease are wonderful because they take it all off the burden of the rest of us. Because women who have autoimmune disease tend to have multiple autoimmune diseases. So you can have Hashimoto's thyroiditis and rheumatoid arthritis and insulin-dependent diabetes and throw in some other stuff. So it's usually like breeds like. So if you have an autoimmune disease, you're much more likely to have another autoimmune statistic is. But Scott's going to tell us because he's consulting Mr. Google there, Dr. Google.
Actually,
He's not. I'm thinking of my patients. I don't have a single patient that has type 1 diabetes who's also got rheumatoid arthritis. One. I have one patient. Most of my patients have type 2 because I live in Michigan where everybody's morbidly obese. I have a patient with hemochromatosis who has diabetes, but that makes no sense. Okay, any other questions? Thank you so much for coming and spending your Friday night with us, and that means so much. Please come to the conference. If you don't come to the conference and your friends to the conference is going to be really unusual this year. It's going to be heavy psoriatic arthritis, ankylosing spondylitis. We have some super cool talks on lupus, childhood pain, kind of cool stuff. We also have a panel on complementary and alternative medicine with Uni and physical therapy and occupational therapy, complementary and alternative therapy. We have a panel on the generations of nursing and how to deal with each other, how do we get into nursing, which will then segue into mentoring. And so kind of hooking people who are new into rheumatology in with an RNS member who maybe has been in rheumatology a little bit longer. We have the first day immunology boot camp. It's just going to be the best conference ever. It's going to be amazing. We always have very big names because we're from all over the country. So we have doctors from Cleveland Clinic and doctors from Johns Hopkins and big names. There's going to be an amazing talk on adherence from a doctor, which is shocking to me that there's going to be a doctor talking about adherence because I didn't think they even knew about that. But it was amazing the way that he talks about you shouldn't go into an office with glass windows and a visa sign, right? Because the patient's thinking they just want my money and they don't talk to me. So think about that, about how to get your patients to stick with their medication. And he's a dermatologist, so he knows all about how the patients use their creams like 2 days before they're coming back, right? And not like the 2 weeks before. So we have some big, have the confirmed section too. Patient triage, prior authorization, adherence, pain management. Just amazing, amazing things going to go on.
Last year, we had a speaker who did research on TNF, alpha blockade, and sepsis, and how he had rescued some
The
patients.
MAS.
And, you know, I was like in the front row, you guys taking notes. It was so amazing. And that was last year's conference. I was so amazing.
I always learn something. I'll always learn something.
Can I add to that?
Yes.
It was amazing at the conferences to hear the nurses present as well.
Mhm.
That is
We're generally heavy dominant nurse presenters because we're a group of nurses. It's making more sense. The thing the Rheumatology Nurses Society has done for me, I was with American College of Rheumatology Healthcare Providers, and that just wasn't my home. Vicki Ruffing, who started the Rheumatology Nurses Society, was a very smart woman. She heard me lecture. We worked on projects together, so she invited me to her conference to be a speaker because I was always too busy to go. So she invited me down to Tampa to be a speaker at the conference. And when I'm sitting in a room of 400 nurses that all do the same exact thing that I do for a living and have the same challenges, it was awesome. I found my home. These women are all very, very passionate, and men are very passionate about what they do and taking care of patients, and our whole mission is education. There is no money gain in the Rheumatology Nurses Society. This is all about taking care of patients and educating each other about what to do to better our patients' outcomes.
One thing to point out